Hello, I'm Scott Schiffman, and I'm an assistant professor and fellowship director at the University of Rochester. And I will be talking about MRI shoulder arthrography, interpretation, and variants. As an overview to this presentation, we will start out by reviewing our MRI protocol. We'll briefly review normal anatomy, and then we'll look at pathology and variants, which involve the superior labrum, the anterior inferior labrum, and the posterior labrum. And then finally, we'll conclude with additional pathologies which you might detect on MRI shoulder arthrography examinations. Our MRI protocol takes advantage of intermediate fat-saturated and T1 fat-saturated sequences in the axial, coronal, and sagittal planes. The idea behind this is that you're going to image the glenoid and the labrum in all three planes. With contrast on board, you have distension of the joint, which will make detecting labral tears more obvious. And then in patients who we suspect a history of dislocation or macro instability, additional sequences to consider adding is the idea of this ABER view, or the abduction external rotation view, in which the patient will place their arm behind their head. And this view accentuates labral tears of the anteroinferior quadrant by placing tension on the anterior band of the inferior glenohumeral ligament. And another sequence to consider adding is the idea of a sagittal T1 or proton density sequence, which will help evaluate for glenoid bone loss related to a bony Bankart fracture. Now, the anatomy of the glenoid has been described as looking like an inverted pear shape, or Dr. Donald Resnick often calls it looking like an avocado. I had my eureka moment when I was eating a mango, and I sliced the mango, and it came out looking like a glenoid to me. And I would point your attention to one of the unique features of glenoids that you'll encounter on MRI imaging, which is this anterior concavity. And this concavity will let you know the anterior aspect of the glenoid. Now, the best plane to assess labral tears is having a plane that cuts the labrum completely perpendicular to the labrum, in which case your labrum will come out looking like a black triangle. I wanted to point out a potential pitfall, which is when you advance your coronal plane more posteriorly, you start cutting the labrum at a more oblique angle. And as you go more posteriorly, the image of the labrum becomes more blurry because you're volume averaging and you're not cutting it completely perpendicular. And this will confound your interpretation for labral tears. Ideally, in the future, we'll do 3D imaging with thin slices, and this will allow for reconstructions in which we could create radial planes of imaging, where you can imagine slices that are cutting the labrum always perpendicular to the labrum, and this will allow for detection of labral tears more easily. Now, the anatomy of the glenohumeral ligaments has been discussed. On this image, we could see nicely the coracohumeral ligament extending from the coracoid in the direction of the humerus and glenoid. Inferior to that, we see the superior glenohumeral ligament, which is extending anteriorly and merging with the joint capsule. Interposed between the subscapularis and the anterior labrum, we could see the middle glenohumeral ligament. And then more inferiorly, inserting on the anterior inferior aspect of the glenoid, we could see the anterior band of the inferior glenohumeral ligament. In the axial plane, we could see nicely at the level of the coracoid process, the superior glenohumeral ligament extending anteriorly and merging with the joint capsule. When we get to a mid-axial projection, we can see the middle glenohumeral ligament projecting between the anterior labrum and the subscapularis. When we move more inferiorly, we could see the anterior band of the inferior glenohumeral ligament. And keep in mind that there's also a posterior band of the inferior glenohumeral ligament and multiple striations of the inferior glenohumeral ligament complex, which help to form the axillary pouch. Now, when you place a patient in this ABER projection where their arm is behind their head, it's important to understand how this will distort anatomy on the MRI sequence. The important structures to be aware of when you're looking at the MRI of the ABER anatomy is the anterior band of the inferior glenohumeral ligament which should be firmly adherent to your anterior inferior labrum, and this should also be firmly adherent to your anterior inferior glenoid. In this case, we could see that there's a separation of the labrum from the anterior inferior glenoid, or a Bankart abnormality. Also, on these ABER projections, you're getting a nice look at the posterior-superior aspects of the glenohumeral joint. In this case, you can nicely see the infraspinatus insertion on the greater tuberosity. Now, as for a discussion of superior labrum pathology and variants, the one thing to keep in mind is that when you get into this quadrant of the glenoid, this is where the majority of your normal variants will live, particularly in the superior and anterior superior quadrants. And the pathology is predominantly, pathology of the superior labrum is predominantly labeled as a slap tear or superior labral tear from anterior to posterior. We will also discuss the idea of a cartilage injury called a slap fracture, and then we'll also evaluate injuries that happen in the throwing athletes, such as internal impingement and common paralabral cysts that occur from a superior labral tear. An important concept of the glenohumeral joint with regards to slap tears is this idea of labroligamentous seal. Essentially, the glenohumeral joint is stabilized by the labrum and ligamentous structures. My analogy to this is looking at a pressure cooker. You'll notice that the top of the pressure cooker is lined by this silicone O-ring. And if you did not have this silicone O-ring and you tried to cook food in this pressure cooker, you would wind up with steam seeping out of the sides of the pot. This O-ring helps stabilize the pot and keep pressure within the pot to allow you to cook foods. And this is the analogy to a labrum. Similarly, in plumbing fixtures, you'll notice that there's also an O-ring to prevent leaking water. So when a patient develops even the smallest of labral tears, it creates a situation of microinstability of the joint because you've lost your labroligamentous seal. And this will result in two things. It will allow labral tears to propagate and extend, and it will also place the patient at increased risk of rotator cuff pathology. An important concept to understand is that the biceps tendon is coming up in the bicipital groove and inserting on the superior labrum and supraglenoid tubercle. And a common injury mechanism that's going to involve your labrum and create these labral tears is the idea of a peel back mechanism. When a patient places their shoulder in the extremes of external rotation and abduction, it creates a torque-like motion on the biceps tendon, which will create a force in the posterior direction on the superior labrum. My analogy to what this does, using a soda can analogy on the top of a soda can, imagine if you were to bend the top of a soda can back and forth over and over again. If you kept doing this motion, eventually you would wind up with a fatigue fracture occurring at the base of the soda can top, and then it would pop off. This similar pathology is occurring at the superior labrum as a result of motion of the biceps tendon. Now, there are at least 10 types of slap tears described in the literature, but I would emphasize that rather than trying to memorize all 10 types of slap tears, I think it's important to understand that the surgeons are most interested in types 1 through 4, and then understanding that the majority of the types after 4 are basically extensions of a type 2 labral tear, whether it extends anteriorly, whether it's involved with a labral flap, whether it's extending along the glenohumeral ligaments, extending posteriorly, or extending to involve the entirety of the labrum. So I would recommend that if you were to memorize any of these types, I would recommend learning the Snyder classification, which is types 1 through 4. Type 1 is simply fraying of the superior labrum. Type 2 is a chondrolabral junction separation at the superior labrum, and that's the most common type. And then types 3 and 4 are referred to as a bucket handle tear of the superior labrum, or type 4 is involving the biceps tendon in addition to the labrum. Again, here's a graphic image demonstrating the biceps tendon. This is the peel back injury mechanism, where with external rotation, you create this torque-like motion on the superior labrum, which over time with the back and forth motion will create a labral tear at the chondrolabral junction. Other injury mechanisms that are proposed are with more acute trauma. You can imagine a traction injury where the biceps tendon is suddenly tugged, or you can imagine a compression injury where the humeral head is essentially jammed into the superior labrum. However, most of these slap tears are chronic from repetitive trauma. So the question might come up, how do you differentiate a slap tear from a normal variant? So some of the imaging features that will push you more in the direction of a slap tear is that the signal abnormality will be greater than 2 to 3 millimeters in extent. The margins will be irregular. And in general, slap tears will propagate laterally into the substance of the labrum rather than extending medially along the glenoid rim. Additionally, in the axial plane, you should be able to see both anterior and posterior extension of the labral tear, especially posterior to your biceps labral anchor. So this case is showing nicely contrast from the joint, extending through the chondrolabral junction tear into the substance of the labrum, and this is a wide irregular margin. As these slap tears get worse in extent, we can see in this case contrast extending at the chondrolabral junction and then extending into the substance of the labrum. On the axial projection, we could see that the labrum is lifted off of the glenoid, and the tear is propagating posteriorly, posterior to the biceps labral anchor. In this patient, as we went more inferiorly, we could see that there's tears that are propagating at both the anterior and posterior chondrolabral junction. And this would be important to include in your report so that it gives the surgeon a better idea of the extent of the labral tearing. Similarly, in this patient, we have a superior labral tear with involvement at the chondrolabral junction and extension into the substance of the labrum. We have a detachment of the labrum from the superior glenoid. And in this patient, as you would go more inferior on the slices, you could see the tear propagating along the posterior chondrolabral junction. And this sagittal image, when you catch it properly, nicely demonstrates the complete extent of this, extending from the posterior superior labrum all the way down the posterior glenoid to involve the posterior inferior labrum. So this would be a slap tear with posterior extension, also a slap tear type 8. This patient was a Major League Baseball player who is currently in the minor leagues. And he was experiencing decreased velocity, decreased accuracy. And again, we see that the labrum is completely torn in multiple directions with contrast imbibing within the labral substance. We could see on the sagittal image the extent of the labral tear on sequential images, and we could see that it's extending posteriorly. And then when we go to a more posterior coronal slice, we could see the formation of small paralabral cysts. So these are all findings of a slap tear with small paralabral cysts that are extending posteriorly. Now, one thing to be familiar with is this idea of the bucket handle slap tear. Essentially, a bucket handle slap tear is splitting the labrum into two components, where the inferior component is displaced inferiorly into the glenohumeral joint. As you can imagine, having this extra labral fragment in the joint is going to produce symptoms of pain, clicking and locking sensation within the joint. Another concept introduced by Stoller is this idea of a slap fracture. And by slap fracture, he's not referencing an injury to the bone. However, he's referencing an injury to the articular cartilage. So you could see in this humeral head, normal articular cartilage along the superior aspect of the humeral head. However, involving the supromedial aspect of the humeral head between my two arrows, you could see an area where you essentially have full thickness cartilage loss. So the key takeaway is that in patients that have slap tears, they have a unique pattern of cartilage loss over time. And an important place to look is this supromedial quadrant of the humeral head to assess for cartilage loss. And the idea of a full thickness cartilage loss is referred to as a slap fracture by Stoller. Now, in the throwing athlete, a specific pathology that can occur is what's referred to as internal impingement or posterior superior impingement. The idea behind this is that in the throwing athlete, in the extremes of abduction and external rotation, there's a collision that will occur between the posterior superior aspect of the greater tuberosity and the posterior superior aspect of the glenoid. And then the structures that are wind up entrapped in this collision is that you wind up getting fraying of the posterior superior labrum. You wind up getting these synovial herniation cysts deep to the infraspinatus, involving your posterior superior greater tuberosity. And oftentimes you also get partial thickness tearing along the undersurface of the infraspinatus. These combination of findings should tell you that you're dealing with a patient that does overhead activity, such as either a baseball pitcher or a volleyball player who does spiking motions. Another takeaway from these type of throwing athletes is that they'll develop this sclerosis along the posterior aspect of the glenoid. And this is unique to the throwing athlete because the center of rotation of the shoulder changes from the center of the glenoid to a more posterior superior aspect of the glenoid to help enhance, this is like a normal adaptation to increase velocity when you're a baseball pitcher. And this puts exaggerated stress on your posterior glenoid. So when patients have this internal impingement syndrome, they'll present with decreased velocity or decreased accuracy. Now, paralabral cysts are a result of labral tears at the contralabral junction. And in the superior labrum, there are two common locations of paralabral cysts that could result in pathology. One of which is in the suprascapular recess, and one of which is in the spinoglenoid notch. Here we have a posterior superior labral tear, which I'm not showing on these images. However, the posterior superior labral tear is feeding through this neck into a ganglion cyst or paralabral cyst, which in this case is located in the spinoglenoid notch. The spinoglenoid notch is demarcated by the spine of the scapula and the glenoid. And the key thing to know about this location is that in the suprascapular notch, you have your suprascapular nerve, which supplies your supraspinatus and your infraspinatus. But when you get to your spinoglenoid notch, this is where the suprascapular nerve will branch and send a nerve individually to the infraspinatus. So in this case, you could see diffuse increased attenuation, increased signal of the infraspinatus as a result of denervation edema involving the infraspinatus as a result of compression of the nerve that supplies the infraspinatus from this cyst in the spinoglenoid notch. So the question will come, how do I distinguish a slap tear from a normal variant, namely the sublabral recess? The sublabral recess exists in the 11 o'clock to 1 o'clock position. And the hallmark findings is that you're going to have an abnormality at the chondrolabral junction, which is less than 2 millimeters in thickness, and it parallels the glenoid and extends medially rather than extending laterally into the labral substance. Additionally, on your axial images, you shouldn't see it extend far posterior to your biceps labral anchor. Now, the sublabral foramen is another normal variant. This normal variant is isolated to your anterosuperior quadrant. And the idea behind the sublabral foramen is that you have abnormal development of your anterosuperior labrum, in which the anterosuperior labrum briefly migrates off of the glenoid and then rejoins the glenoid at the mid-anterior portion. So on sequential axial images, first you'll see a defect at the anterior superior chondrolabral junction. On the subsequent image, you'll see that defect widen. And then on a subsequent image, you'll see that basically rejoin the anterior mid-glenoid labrum. So when you see an abnormality such as this, where because the labrum is lifting off of the glenoid and rejoining and forming this hole or foramen, and it's limited just to that anterosuperior quadrant, this should not be confused with a slap tear. And if you have an abnormality that's not extending posteriorly from the anterosuperior quadrant, the emphasis should be that you should consider a normal variant before you think of superior labral pathology. Another type of pathology that's unique to the anterosuperior quadrant is this idea of a Buford complex. The Buford complex is a combination of findings including a thickened or cord-like middle glenohumeral ligament, which continues in contiguity with the superior labrum, and you have an absent anterosuperior labrum. So on these sequential axial images, we could see that thickened or cord-like middle glenohumeral ligament. And here we could see that middle glenohumeral ligament merging with the superior labrum. And we could see that there was absence of the anterosuperior labrum. Another example of a Buford complex, we could see that cord-like or thickened middle glenohumeral ligament, which is nicely demonstrated in this axial image right here. And then we have absence of the anterosuperior labrum. Onward to pathology involving the anterior inferior labrum. Pathology involving the anterior inferior labrum is commonly a result of an anterior shoulder dislocation. So in this case, we're talking about macro instability instead of micro instability. As such, we will discuss the idea of a Hill, Sachs, and Bankart defect. And then we'll go into the various labral defects that could occur at the anterior inferior quadrant of the glenoid. This graphic nicely illustrates them, ranging from your bone or soft tissue Bankart, Perthes, GLAD, ALPSA, and then we'll also talk about injuries to the inferior glenohumeral ligament complex, including Hagel, Bagel, and GAGL. I will talk about how to distinguish a Hagel from axillary pouch contrast extravasation. And then for the normal variant involving the inferior glenoid, we will talk about the glenoid bare spot. So patients that have an anterior dislocation have macro instability. And when you have a situation of macro instability, you're anticipating labroligamentous injuries. In this case, not only is the shoulder anteriorly dislocated, but the humerus is impacted on the anteroinferior glenoid. This is referred to as engagement. And you can imagine that this would be difficult to reduce. However, after they reduce this dislocation, it shouldn't surprise you that you have the sequelae of an anterior shoulder dislocation, which include this impaction fracture of the posterolateral aspect of the humeral head, referred to as a Hill-Sachs deformity, as well as this curvilinear bony fragment adjacent to the anterior inferior glenoid, or a bony Bankart fracture. Now with Hill-Sachs deformities, a concept that is important to understand is this idea of on-track or off-track Hill-Sachs defects. If the Hill-Sachs defect is involving the humeral apex or is located medial to the humeral apex, this is referred to as on-track. If the Hill-Sachs defect is lateral to the humeral apex, this is called off-track. And the concept of track, if you're on track, this means that you're more prone to have a dislocation event with re-engagement. So these patients are more likely to have re-engagement of this Hill-Sachs defect on the glenoid, and this is more requiring of surgical intervention more urgently than someone that has a Hill-Sachs defect that is off track. Both of these can engage and redislocate, but the on track is more concerning to the surgeon. When looking at bony Bankart defects, it's important to understand that you're looking for how much of the glenoid bone stock is being lost from this bony Bankart abnormality. The way to assess this is you create a best fit circle to the lower half of the glenoid, and then you see what percentage of that cross-sectional area is taken up by this bony Bankart fracture. And if this bony Bankart fracture is taking up more than 20 or 25% of the cross-sectional area of your lower glenoid, this is concerning because it means that the patient is going to be unstable and have recurrent dislocation. So the patient will benefit from surgical intervention with a lateral J procedure to augment that anterior inferior glenoid. I will also call your attention to this axial image where after you've had a bony Bankart abnormality, the anterior inferior aspect of your glenoid takes on this unusual trapezoidal shape, and you've lost that pointy edge of the glenoid. This becomes more important when you're looking at MRI images so that you could get a better understanding of what you're looking at. So here's an MRI image from a shoulder arthrogram. I will point out how to look for the Hill-Sachs defect. We go to the level of the coracoid process, or slightly more superior than the coracoid process. And we're looking for this site of an impaction fracture involving the posterolateral aspect of the humeral head. And you can see nicely the bone marrow edema associated with this impaction fracture. As we move to the anterior inferior aspects of the joint, we could see that the glenoid has taken on that trapezoidal morphology where we've lost that corner of the glenoid. And what's occurred here is we've had periosteal stripping. The labrum is completely displaced out here, and filled into this space is basically granulation tissue. So when you're looking at these MRI images, sometimes you'll see contrast imbibe itself between the periosteal stripping, or sometimes if these are more chronic, you'll get this granulation tissue. So my recommendation would be when you see these abnormalities to start getting a sagittal T1 or proton density image. On the sagittal proton density image, in this case, you can nicely see the bony Bankart abnormality, as well as the deficiency of the anterior inferior glenoid. Another case of a patient with a Hill-Sachs and Bankart abnormality, you can nicely see this on-track Hill-Sachs defect. And then when you get to that anterior inferior quadrant, you could see the stripping of the periosteum with tearing of the periosteum and complete displacement and tearing of the anterior inferior labrum, in this case with contrast getting between the periosteum and the displaced labral fragment. Now for the various variants that could occur following an anterior dislocation involving the anterior inferior labrum, here's an axial image from a shoulder arthrography, and you'd be hard-pressed to necessarily call a tear of the anterior inferior labrum. But then you place the patient into a ABER position, and the ABER position is going to place tension on the inferior glenohumeral ligament complex and exaggerate tears that are occurring at the anterior inferior labrum. In this case, you can see contrast imbibing itself at the chondrolabral junction between the labrum and the articular cartilage, demonstrating periosteal stripping, and the labrum is attached to the periosteum waving around like a flag. A Perthes injury is essentially a non-displaced chondrolabral junction injury with stripping of the periosteum, and sometimes you require this ABER position to exaggerate these findings. Another example of a patient with a Perthes injury, you could see stripping of the periosteum and displacement of the labrum with essentially a non-displaced chondrolabral junction injury at the anterior inferior chondrolabral junction, and contrast permeating deep to the stripping of the periosteum. Now the GLAD injury, or the GlenoLabral articular disruption, is referring to a full thickness cartilage defect involving the anterior inferior glenoid, which propagates into the labrum and is associated with anterior inferior labral tears. A better example on the next slide, we could see a full thickness cartilage defect involving the anterior inferior glenoid articular cartilage with extension into the anterior inferior labrum. In this case, the full thickness cartilage defect resulted in this cartilage flap, which extended inferiorly into the axillary pouch. Another injury that could occur following an anterior shoulder dislocation is this idea of an ALPSA injury, or anterior labral periosteal sleeve avulsion. The idea here is that you wind up stripping the periosteum of the glenoid, and then you have complete displacement of your anterior inferior labrum, which gets sandwiched between this periosteal stripping and the glenoid. So an image like this shows the periosteal stripping and that displaced anterior inferior labrum basically sitting in that crevice between the stripped periosteum and the anterior inferior glenoid. Now, after an anterior shoulder dislocation, you can also have injuries to your inferior glenohumeral ligament complex. And these are referred to as GAGL or BAGL, or humeral avulsion of the inferior glenohumeral ligament. So the avulsion of the glenohumeral ligament is occurring from the humeral attachment site at the anatomic neck of the humerus. And when the ligament retracts, it forms this redundant portion of the inferior glenohumeral ligament, which looks like the letter J, and this is referred to as the J sign. When you have a humeral avulsion of the glenohumeral ligament, obviously contrast from the joint will now be able to extravasate through this defect into the axilla. If you think that these are associated with small bony fragments which are avulsed from the anatomic neck of the humerus, then this could be referred to as a BAGL, or bony humeral avulsion of the inferior glenohumeral ligament complex. Similarly, you could also have abnormalities at the glenoid attachment of the inferior glenohumeral ligament complex. In this patient, we have an avulsion of the glenoid, avulsion of the inferior glenohumeral ligament complex, referred to as a GAGL. And similarly, we could see contrast from the joint extending through the defect created by this avulsion of the glenohumeral ligament complex, now deep to the subscapularis and extending into the axilla. So the question will come up then, how do you distinguish a GAGL from contrast extravasation? So you'll do an arthrogram on a patient, and the arthrogram will look normal while you're in the room. And then the patient will later go on to get an MRI. And while you're looking at the MRIs, in some patients, usually young female patients, or patients who may have had a pre-existing joint effusion where you've over-distended the joint, in some patients, you'll see contrast leaking inferior to the axillary pouch. And usually you're doing these MRI arthrograms on patients who may have had instability episodes. So you'd be unsure, are you looking at an inferior glenohumeral complex injury, or is this simply just contrast extravasation from over-distension of the joint with contrast permeating into the axilla? A group in San Diego looked into this and created these findings, which are suggestive of either a GAGL or contrast extravasation. And I believe the key takeaway is that if you have isolated disruption of the posterior axillary pouch, meaning that on your posterior coronal images, if you're seeing the seepage only occur there, that's much more specific for contrast extravasation. Whereas if you have findings of either a J sign, torn anterior band, or if you have this abnormal thickening of the inferior glenohumeral ligament complex, these are signs more suggestive of a GAGL injury. Now, the normal variant to be aware of involving the inferior glenoid is this idea of a glenoid bare spot. This, for all intensive purposes on your images, will look like a small full thickness cartilage defect. However, this is not actually a cartilage defect, but a normal variant. And the way to recognize this is that if you best fit a circle to the lower half of the glenoid bare spot occurs directly in the center of that circle. So if you see an abnormality of the cartilage just limited to the center of the circle of the inferior glenoid, be aware that this is a normal variant and not a small full thickness cartilage defect. For pathology involving the posterior labrum, this is the result of a posterior dislocation or subluxation event. And the terminology is similar to the ones for the anterior shoulder dislocation, but with reverse added. So we have our reverse Hill-Sachs, our reverse Bankart. We could have reverse Perthes, or we could have reverse abnormalities of the GLAD. We could have reverse ALPSA, for example. In the throwing athlete, there's a unique pathology called a Bennett lesion involving the posterior glenoid. And we'll also talk about paralabral cysts, which could arise from the posterior labral tear. So here's an example of a patient with a posterior shoulder dislocation. You could see nicely on this Y view that the humeral head is posteriorly dislocated relative to the center of the glenoid. On this AP view, you can see the humeral head is overlapping with the glenoid, and this is completely abnormal and not a position that people can get into. And then you see on this axillary projection, not only are we posteriorly dislocated, but the humeral head is impacted on the posterior glenoid, creating this impaction fracture of the anteromedial humeral head, which is referred to as your reverse Hill-Sachs deformity. And this is also engaged on your posterior glenoid. So when you're looking at these patients after they've been reduced on an MRI arthrogram, the hallmark findings is that you want to see this impaction fracture involving the anteromedial humeral head with associated bone marrow edema, representing your reverse Hill-Sachs deformity. And then at the posterior glenoid, you're going to see posterior tearing of the labrum at the chondrolabral junction, as well as fracturing of the posterior glenoid. Sometimes this is better seen on your sagittal T1 or proton density images, where you can see nicely this displaced bony fragment, displaced posteriorly, compatible with a reverse bony Bankart. Similarly, in this patient, where you could see that the humeral head is posteriorly subluxed on the glenoid even during this examination, you could see a labral tear involving the posterior chondrolabral junction with stripping of the periosteum, and also bony injury to the posterior glenoid, which is nicely demonstrated on the sagittal T1 image, where we could see cortical bone displaced posteriorly. So this is demonstrating a reverse Bankart abnormality. Now, bear in mind that the patient population that will get these pathologies of the posterior labrum are patients that are involved in athletics that are constantly putting this posterior subluxation stress on the joint. This could be patients that are doing weightlifting, or patients that are like offensive linebackers in football who are constantly having to resist a force in this direction. And when you wind up with these posterior subluxation episodes, it creates tearing at the chondrolabral junction of the posterior labrum. In this case, we could see a non-displaced chondrolabral junction injury with some stripping of the periosteum, and this would be considered a reverse Perthes injury. A pathology that's unique to the throwing athlete is this idea of a Bennett lesion. The Bennett lesion is a sequelae of constant stress being transmitted through the posterior band of the inferior glenohumeral ligament. And with that constant stress, what you wind up having is basically periostitis and bony proliferation at the posterior glenoid rim. In this case, you could see this abundant bony proliferation at the posterior glenoid rim as a result of repetitive stress from the posterior band of the inferior glenohumeral ligament. When you do MRIs in patients with the Bennett lesion, it shouldn't shock you that you find abnormalities of labral tearing, as well as sclerosis and thickening of the cortex of the posterior glenoid. So be aware that patients with the Bennett lesion is commonly seen in like the throwing athlete, and it's associated with posterior labral tears as well as posterior and superior rotator cuff pathology. And you'd imagine that an athlete that has this type of Bennett lesion will also have symptoms of that internal impingement syndrome as we discussed earlier. Now, paralabral cysts can also occur from tears at the chondrolabral junction of the posterior inferior labrum. Here we see a small non-displaced chondrolabral junction tear at the posterior inferior labrum. And then we could see it's associated with a paralabral cyst which dissects inferiorly into the quadrilateral space. When you have a paralabral cyst that's involving your quadrilateral space, the nerve of concern would be the axillary nerve, and the muscles of concern would be the deltoid or teres minor muscles, where you would want to look for denervation edema. Finally, to review additional pathologies that you might detect on MRI arthrogram and examinations, the clinicians will see patients and they will think the patients have a labral tear. However, the patients may have any one of these numbers of pathologies, which you might discover when you do the MRI shoulder arthrography. So a patient may have adhesive capsulitis. They may have rotator cuff tears, which are able to better be seen given that we're having contrast within the joint. So we can nicely see partial thickness articular sided rotator cuff tears as well as full thickness rotator cuff tears. Subacromial subdeltoid bursitis might be more confidently diagnosed on shoulder arthrography because we have the advantage of having a T1 fat saturated sequence. And sometimes injuries to the acromioclavicular joint are subclinical or subradiographic, and the first discovery may be during a shoulder arthrography examination. And we could also detect loose bodies during shoulder arthrography. So adhesive capsulitis, and this is an excellent example of that, the hallmark findings is thickening of the axillary pouch, edema within the axillary pouch, and edema within the rotator interval fat. So the combination of thickening of the axillary pouch, edema of the axillary pouch, edema of the rotator interval fat are findings which are suggestive of adhesive capsulitis. Another finding which is apparent in this patient but not always seen is this pericapsular edema, which is extending along the entirety of the joint capsule. So you can imagine that this patient's axillary pouch is completely inflamed and scarred, and this results in a very narrowed axillary pouch. So you can imagine if you're doing shoulder arthrography in this patient, you might not be able to inject the full amount of contrast that you'd like. You might reach 6 cc's of contrast and feel very high resistance. And then you'll see a narrowed axillary pouch, and you'll see contrast preferentially pooling in the biceps tendon sheath. So these are findings on MRI that would suggest the diagnosis of adhesive capsulitis. For rotator cuff tears, an advantage of having contrast within the joint is that on this coronal T1 fat saturated image, you can see nicely that contrast is imbibing along the undersurface of the supraspinatus, better illustrating a partial thickness articular sided tear of the supraspinatus. This patient also had a tear of the posterior superior labrum. In this patient with a partial thickness articular sided rotator cuff tear, there was also a delaminating component of the tear, which propagated in between the fibers of the supraspinatus and propagated medially. Oftentimes, these delaminating tears are associated with cysts at the musculotendinous junction. And you can nicely see that even though this is well demonstrated on our T2 FATSAT sequences, with contrast, you could confidently call the articular sided abnormality, and you could see the contrast extending along the site of delamination. Here's an example of a rim rent tear on our intermediate fat saturated sequence. We've got this peeling off of the supraspinatus insertion at the greater tuberosity. And the question might become, how much of the articular side is involved and how much of the bursal side is involved, or is this completely interstitial? Then we give contrast on our shoulder arthrography, and we see that contrast communicates into the rim rent tear. This would suggest that the articular component is definitely involved, and that this tear is both partial thickness, articular-sided, and interstitial, nearly extending completely all of the way through the bursal side of the tendon. And we know that it doesn't extend completely because we don't see any contrast accumulating in the subacromial subdeltoid bursa. So here's an advantage of how we could take advantage of contrast in the joint. A patient with a full thickness rotator cuff tear, here you do an arthrogram and you notice that contrast is communicating from the glenohumeral joint into the subacromial subdeltoid bursa. And this is diagnostic of a full thickness rotator cuff tear on the arthrogram. It shouldn't surprise you that when you do the MRI in this patient, that you can see a torn and retracted supraspinatus tendon, retracted close to the supromedial aspect of the humeral head. And then you can see the contrast communicating into the subacromial subdeltoid bursa. The advantage of the MRI shoulder arthrography is we're getting this T1 fat saturated sequence. So here we see a fluid collection within the subacromial subdeltoid bursa, and we see that there's no contrast in this fluid collection on our T1 fat saturated sequence. So this helps more confidently diagnose subacromial subdeltoid bursitis. Now, patients may come in with an acromioclavicular injury that's subclinical or subradiographic. They get the MRI looking for a superior labral tear, and then you discover that actually there's ligamentous injury at the acromioclavicular joint, ligamentous injury at the coracoclavicular joint, in this case in a patient with a type 3 acromioclavicular separation, which was not known to the clinician prior to the MRI shoulder arthrography. Similarly, because we're dealing with a patient population that does a lot of weightlifting, who often get these slap tears, the clinician might order a shoulder arthrogram looking for a slap tear, and then incidentally you might discover that at the AC joint you have asymmetric edema involving the distal clavicle with subtle erosions of the distal clavicle along the lateral margin, subtly apparent on the radiograph, which is referred to as post-traumatic osteolysis of the distal clavicle, or a weightlifter's osteolysis of the distal clavicle. So this is something to be aware of on your axial slices through the acromioclavicular joint. Look for asymmetric bone marrow edema, preferentially involving the clavicle, which might help suggest this pathology. Finally, a case to wrap up all the pathologies we talked about, the idea of finding loose bodies within the joint. Here we are doing a shoulder arthrogram, and we could see essentially a filling defect within the joint, which persists even on our late images. Subsequently, we get the MRI examination, and on this MRI examination, we see a site of impaction fracture of the posterolateral humeral head with bone marrow edema compatible with a Hill-Sachs deformity. At the anterior-inferior glenoid, we see a full thickness cartilage defect compatible with a GLAD injury. And then that loose body is correlating with this cartilage fragment, which is displaced into the posterior aspect of the joint. So this full thickness cartilage defect has now become a loose body within the joint. So hopefully this connects some of the pathology as we discussed earlier, and all of this as a result of a previous anterior shoulder dislocation. So I would like to say thank you for listening, and here's my contact information.